To begin, thank you to the organisers of the conference for the opportunity to present our work investigating the impact of the COVID-19 virus and related policy responses on smoking and nicotine use. The study was funded with a grant from the Foundation for a Smoke-Free World, a US non-profit 501c3. The full funding statement is available on this slide. Also, myself and my colleagues at BOTEC have consulted for firms in the tobacco industry, as well as regulators and philanthropic research funders. The link between stress and nicotine consumption is well established, and for many the prospect of illness and death, enforced isolation, and economic downturn that COVID brought has made life stressful. It stands to reason then that the pandemic has affected the use of tobacco and nicotine. Additionally, a reduction in time spent in areas where smoking is banned and changes in free time and disposable income may have increased consumption of tobacco and nicotine products like e-cigarettes. Conversely, reductions in disposable income, a heightened attention to health and well-being, and less time spent around environmental triggers, and more time spent around non-smokers may have decreased consumption. These possibilities are not mutually exclusive, and both effects may have occurred simultaneously in different subnational groups. Governments' responses to the pandemic likely also affected the availability or perhaps accessibility of products, and misinformation about the interaction between nicotine and the virus could have changed consumers' perceptions of risk. During COVID, pre-existing tobacco restrictions have been extended ostensibly to protect public health, or at least safeguard the provision of health services and reduce opportunities for viral transmission. Spain's extension of their smoke-free regulations serves as one example. However, there have also been novel restrictions affecting tobacco and nicotine. The restrictions on international travel functionally denied duty-free sales to most smokers. The general restrictions on businesses, including limits on operating hours and capacity, and forced closures of non-essential businesses may have further reduced product accessibility. In some contexts, vape stores were deemed non-essential and shuttered, at least for a time, while stores such as grocers and gas stations, which often sell cigarettes, remained open. Finally, there have been specific restrictions on tobacco and nicotine products, such as the restrictions on online purchases enacted by France. But the most extreme example of specific tobacco restrictions during the era of COVID come from South Africa and Botswana, where the sale of cigarettes and alcohol was banned during the spring and summer of 2020. COVID-19 messages have also quickly been absorbed into the Stop Smoking campaigns, including this one by the World Health Organization. We conducted a structured review of the existing literature to investigate changes in the prevalence and frequency of the use of combustible tobacco and safer nicotine products. Surveys focusing on behavioral adaptations and changes to beliefs, attitudes, and motivations were also included. We processed 352 articles in all, extracted from the PubMed database during April of 2021. Inclusion criteria, displayed on this slide, were designed to maximize inclusivity. This analysis is not intended to establish causal relationships, but to suggest associations that might then be explored further as better quality data emerges. There are a number of limitations with the data. In general, many of the surveys are unlikely to be representative of the wider population, and the reliance upon online survey data creates the risk of recall and reporting bias and social desirability bias. The literature also acknowledges that in the rush to publish, the analytical methods of some studies may be substandard. This may be particularly true of cohort studies in clinical settings, where the accuracy of patient records may be imperfect. Granted, the challenges of providing healthcare in patient settings during the pandemic may make for a difficult environment for data collection. Still, much of the survey literature pertains to the first few weeks or initial months only of the lockdowns, and the ultimate effects of the pandemic may not emerge until much later. It's also unclear whether and for how long observed changes will persist. Time series cohort studies could help answer these questions. Smokers exhibited a bifurcated response in the majority of sources reviewed, approximately 67%. Increased consumption appears to be reported with significantly greater frequency than decreases. Additionally, the extent of the increases appears greater than decreases. Among studies reporting increases, 2/3 reported that increases in smoking frequency were greater than 25%. Conversely, just 13% reported decreased smoking frequency in the same proportion of smokers. 59% of sources reported that the pandemic had increased smokers' motivation to quit or reduce smoking, while 22% also stated that COVID had reduced these motivations among some smokers. Changes in prevalence were less widely reported. Only a handful of the sources reviewed discussed changes in smoking prevalence explicitly. However, there was evidence for both increases and decreases in prevalence driven by the pandemic. So this chart shows the various increases and decreases in smoking frequency reported by the studies identified, with the green bars showing the net effect. A similar bifurcated response was noted among e-cigarette users. Again, increases tend to outweigh decreases in about 3/4 of the sources. And the pandemic also appears to have increased motivation of e-cigarette users to quit or reduce consumption, with increased motivation reported in between 5 and 40% of survey respondents. And again, this chart shows the difference between increases and decreases in frequency of e-cigarette use reported by the studies. Again, the green bar shows the net effect. The literature identifies a number of local environmental phenomena and individual factors that were consistently associated with increased consumption. These include stress and anxiety, isolation, worse mental health, and greater fear of infection, as well as greater nicotine dependence. And generally, the picture this paints is one in which the worst smoking-related COVID responses are concentrated among those who are historically disadvantaged, as may be true of COVID harms in general. And this suggests that COVID-19 may have exacerbated existing smoking-related health disparities. Interestingly, individual-level associations appear to operate in surprising ways in different contexts. For example, given that unemployment has been associated with smoking status, it's perhaps surprising that in Italy and the US, an improvement in smoking habits was associated with unemployment during the pandemic. And it might be that increased free time, or perhaps more time spent around family members as a result of a loss of or a reduction in formal employment, confounds the stress effect. And this topic requires further investigation. The availability of combustible tobacco at essential businesses, coupled with the closure of many vape stores, may have made e-cigarettes harder to obtain than conventional tobacco, and this may have nudged consumers of safer nicotine products back to cigarettes, reversing the public health gains from the original substitution. The duration and extent of this effect requires further analysis. Product bans, such as those enacted by South Africa, do not extinguish consumption. One source estimated that 93% of smokers simply transition to illicit sources, and the consequences of greater illicit trade include lost revenue, $100 million a month according to one estimate, as well as rising enforcement costs at a time when public spending is already being stretched. Illicit markets also bring violence and deny regulators an opportunity to oversee a minimum level of product safety. Ostensibly, the motivation for South Africa's ban was to minimize the risk for viral transmission, but the sharing of newly scarce tobacco and the absence of social distancing during illicit transactions suggest that the risk of tobacco-related COVID transmissions may have been increased by the ban. While social distancing protocols appear to have been effective at flattening the curve, future lockdowns should consider possible unintended consequences, such as increases in risky behavior, and account for them in prospective cost-benefit analyses. To support smoking cessation efforts, vendors of safer nicotine products should be designated as essential businesses. Businesses where combustible tobacco products are sold could also be encouraged to offer SNPs alongside combustible tobacco. If public health officials deem the closure of stores selling SNPs to be necessary, restrictions on online sales to age-verified adults should be avoided. Tobacco taxes should be pursued with reference to increased illicit trade. Taxes should be applied only to combustible tobacco, or at least designed to treat SNPs favourably in comparison. One of the remaining knowledge gaps on this topic relate to COVID's effect on second-hand smoke levels. Did being at home make smokers cut down, or did it expose their families to greater levels of second-hand smoke? This needs to be investigated. Post-pandemic, regulators might consider strengthening smoke-free rules to reverse any effect of social distancing and remote working on smoking. But as remote work is likely to continue, additional ways to discourage smoking in the home will need to be identified. Priority should be given to reduce second-hand smoke exposure in shared and public housing, communities in which smoking rates are often higher. And to encourage compliance, regulators might consider designing smoke-free laws that treat safer nicotine products favourably in comparison to combustible cigarettes.